and also another round of reabsorption of sodium happens again. So that is the work of renin-angiotensin and aldosterone system, which thereby controls the blood pressure in our body. Then there is erythropoietin, which is produced by the kidney, which stimulates the RBC productions, and these are present in the peritubular cells of the kidney. And finally, we have the dihydroxy vitamin D3 or calcitriol, which is produced by the proximal convoluted tubule cells. It activates the vitamin D receptor and it increases the calcium level in the blood by increasing the uptake of calcium from the intestines. So now let's move on to the applied anatomy and physiology. From here on, we look into some of the diseases related to the kidney. We'll start with the congenital anomalies. As you can see, agenesis is the first condition wherein there is complete absence of one kidney, which is found in embryos. Then there is aplasia, that is one kidney among the two stops growing in its very primitive form. In the very beginning itself, it stops growing, and that is what is seen in the middle picture, aplasia of kidney. And then there is hypoplasia, wherein the underdeveloped kidney grows to a little more extent and then stops growing. That is hypoplasia of kidney. So these three are the congenital anomalies. Next, we have polycystic kidney, which is an inherited disorder in which clusters of cysts develop within the kidneys and they enlarge, and finally it affects the normal functioning of the kidney. The next is the horseshoe kidney. As you can see in the picture, the lower poles of both the kidneys are fused together, and it can also ultimately affect the functioning of the kidney. Next is renal trauma. So severe blunt injury to the abdomen or sometimes stab wounds or even gunshot wounds directly over the back can affect the kidney, or in case of blunt injury, the 11th and 12th ribs can penetrate the kidney and thereby it creates an emergency condition. Then we have a condition called floating kidney, or it is called as nephroptosis kidney. Floating kidney is when the covering of the kidney, as we saw earlier in the presentation, that is the perinephric fat. So these coverings help to maintain the position of the kidney. So when this covering or the perinephric fat reduces, thereby the mobility of the kidney increases. As the kidney starts moving from its actual place, it finally results in the kinking of ureter and thereby producing symptoms similar to the urinary calculi. Next, we move on to the infections found. So first one is nephritis, which directly means the nephrons of the kidney are inflamed and thereby affects the function. Next is the pyelonephritis. This is more specific because this occurs usually, it is occurring after an episode of lower urinary tract infection. That is, the bacteria like E. coli travel up to the upper urinary tract and then causes the inflammation of the nephron, which is called as pyelonephritis. Then we have glomerulonephritis, which is even more specific, wherein the glomerulus of the nephron alone is getting inflamed, and this is actually a symptom found in many various important kidney diseases. Next, we have the very famous nephrotic syndrome. So nephrotic syndrome is where there is a proper damage happening in the kidney, and this is also a collection of symptoms happening due to the kidney damage. So here the symptoms can be like proteinuria or low albuminemia, and there is swelling in the face and other symptoms. So that is nephrotic syndrome where the kidney has started damaging. Then we have nephrolithiasis, or more specifically calculi, renal calculi. So here stone develops inside the kidney, and when the stone grows beyond a certain size, it starts affecting the normal physiology and anatomy, and accordingly the symptoms are produced. So we have another point here, which is the renal angle, which is present in between the lateral border of the erector spinae muscle and the 12th rib. With this area is presented with the renal tenderness in the cases of nephrolithiasis. Next we have the kidney disease, which is divided into three types. First is the acute kidney injury or disease, then there is chronic kidney disease, and then there is diabetic kidney disease. So in acute kidney disease, what happens is that there is a sudden episode of kidney failure or damage occurring within a very resuming back with the presentation. The acute kidney injury is the disease wherein there is a sudden loss of the kidney function which happens within a few days. This is usually caused by renal ischemia or crush injury, or often found in patients who are actually hospitalized for so many days. So that is about the acute kidney disease or acute renal failure. Then we move on to the chronic kidney disease, wherein the damage happening to the kidney is in a gradual process, and it happens over a period of months or years, and which in turn which is caused by generally increased hypertension or polycystic kidney, or as we discussed earlier, glomerulonephritis. Then the third type is the diabetic kidney disease, in which the kidney damage is specifically caused by continued increased level of blood glucose, and that is called diabetic nephropathy also. Then we'll move on to the diseases related to the renal vasculature. First, we have the renal artery stenosis, wherein the narrowing of the renal artery is happening, and the narrowing comes as a part of the atherosclerosis, that is, it comes as a part of the general systemic disease, and then the symptoms are produced accordingly and results in the renal hypertension and ultimately in the chronic kidney disease. So that is related to the renal artery. Then we have a syndrome called the renal nutcracker syndrome, wherein the renal vein is being pressed in between the abdominal aorta and the superior mesenteric artery. As you can see it in the picture, it is being pressed in between the two arteries, and hence it causes symptoms like hematuria and also mimics the symptoms of urolithiasis. Finally, we have the renal cell carcinoma, which originates in the lining of proximal tubule cells and which in turn grows and develops over the lower pole of the kidney. So with this, I conclude my presentation, and I would like to thank all the organizers of this program, principal, vice principal, and all other senior faculties for having given me this opportunity to present this on this wonderful occasion. Thank you all once again.
Thank you, ma'am. I now invite Dr. Kartika R. Nair, ma'am, Assistant Professor, Department of Roga Nidana and Vigrithi Vijnanam, to do a presentation on pathophysiology and investigations in renal disease with special reference to chronic kidney disease.
Good evening, everyone. Offering my pranams to the feet of all acharyas of Kamakodimat, Sri Chandrasekhar Saraswati University, Sri Jayendra Saraswati Ayurveda College, all MC members, all dignitaries, all faculty members, students. Today, we are celebrating World Kidney Day. During March, the second Thursday of every March, we are celebrating World Kidney Day to focus the importance of kidney and to increase the awareness of prevention and control of kidney diseases worldwide. Today, I'm going to introduce some of the topics relating to the pathophysiology and investigations in renal diseases with special reference to chronic kidney disease. Renal diseases are a syndromic presentation which starts from the acute renal failure, chronic renal failure, nephrolithiasis, nephrotic syndromes, neoplasms, urinary tract infections, urinary tract obstructions, and renal tubular diseases. So, for the subject proper, we are going with the chronic kidney disease. Chronic kidney disease encompasses a spectrum of different pathophysiologic processes. So, when we are telling about pathophysiology, you should know about what is pathophysiology. Normally, an organ have a physiological functioning. Any derangement in the physiology of an organ leading to a disease is called pathophysiology. So, in what happening in chronic kidney disease, it is a pathophysiological process associated with abnormal and progressive decline of kidney function. Why we are taking chronic kidney disease as specific? Because as 90% of the chronic kidney diseases are asymptomatic in its early stages and will become evident only on the end stage. As there is no symptoms, patient will not consult the physicians. So this increases the morbidity rate of the disease, and it is estimated that by 2024, chronic kidney disease will become the 5th leading cause of death globally. So this increases alerts us the importance of chronic kidney disease. So, what all are the causes of causative factors of chronic kidney diseases? So, initial one is the glomerular diseases, which include primary and secondary glomerular diseases. Next is tubulointerstitial diseases, cystic diseases, and obstructive pathologies and vascular diseases. Glomerular diseases, which includes the changes in the glomerula due to any of the autoimmune trigger. your own immunity will trigger and it will disrupt your organ, especially on the glomerular apparatus, and it will affect our filtration process. Kidney is functioned for the filtration purposes, and the filtration process will be altered, and this will lead to nephrotic syndrome like presentations, and the symptoms will be hypoalbuminemia, proteinuria, edema and all. What is primary glomerular diseases? In what happening in the primary glomerular disease means the pathology will lies on the renal system only. Example, the focal segmental glomerulosclerosis, Alport syndrome, IgA nephropathy. Any of the infections and inflammations of the renal parenchyma will lead to primary glomerular diseases and secondary glomerular disease. So we should be more alert when we are dealing with the secondary glomerular diseases, because these are another pathologies which cause renal impairment, just like systemic lupus erythematosus. Its presentation will be uh, different. It will be integumentary autoimmune like presentation, but it have the role of severe renal damage. So serum sickness nephritis and diabetic nephropathy. Then next is tubulo, as madam introduced that there will be glomerular apparatus, tubular part will be there, collecting part will be there. Any of the damages in the tubular system of the kidney will lead to tubulointerstitial diseases. Means it will lead to tubular part, collecting part or proximal convoluted and distal convoluted tubule will lead to the reabsorption of the electrolytes and the management of the body's water electrolyte system. So here what will happen means, due to the derangement in this system will lead to alteration in the reabsorption. So secretion of important, we will lose some of the important electrolytes from our body, and excretion of a large volume of dilute urine will happen. There may be various causes for the tubulointerstitial diseases, like the vascular causes. What is the vascular causes? It is due to the continued or chronic hypertensive conditions which will cause vascular impairments to the renal arteries, leading to nephrosclerosis conditions, and infectious causes like glomerulopilonephritis conditions, and repeat why it is happening because repeated urinary tract infections, mainly due to certain pathogens like protease and all. And toxic causes is like due to the consumption of any toxic chemicals or continuous administration of non-steroidal anti-inflammatory drugs, just like analgesics, and this will add to the toxic cause of tubulointerstitial diseases. And obstructive causes are, we all know about the obstructive causes of renal diseases, like any of the malignant tumors, prostatic hypertrophies, masses, obstruction due to renal calculi and all. And next one among the which causes leading to chronic kidney diseases are the cystic diseases. Cystic diseases can be congenital, as ma'am told, it can be a congenital and a non-congenital disease. It can be a neoplastic and it can become non-neoplastic also. And all these cystic conditions, everyone assumes that it is only on the from the late early life, or it is like a congenital one, but it can start from the childhood, just like the cradle to the grave, it can happen. And non-neoplastic cystic lesions are polycystic kidney and medullary cystic diseases, simple renal cyst and all. And neoplastic cystic lesions are cystic nephroma and all. When we are going to the symptom complexes of chronic kidney diseases, it can alter the sodium and water balance, potassium balance, elimination of alternation will be happening to the elimination of nitrogenous base, which lead to uremic conditions, erythropoietin dysfunctioning, which will lead to anemic conditions, acid-base balances will be altered and will lead to acidosis and skeletal buffering in the body, and acidic vitamin D production will be affected, and phosphate elimination also will be affected. So as it was in urinary pathology or renal pathology, presentation will not be only in the excretion parameters. It will be all systems of the body will be affected. Just when we are seeing in the uremic condition, it can start from the impaired immune function to it can lead to sexual dysfunctioning also. So assessment of the renal parameters in each diseases is also needed. In other than renal pathology also needed. Then we have to screen the chronic kidney diseases. So, here why chronic kidney disease is important, because 90% of the chronic kidney diseases are asymptomatic in the early stage, and early stage identification is important for the prevention of the condition. So risk groups should be screened, and then we should know about what are the risk groups. The risk groups of chronic kidney diseases are diabetes, hypertension, cardiovascular diseases, especially the ischemic ones, and structural renal tract diseases like calculi and all, and multi-system diseases like systemic lupus erythematosus, and those who are asymptomatic with a positive family history. If any of the family members have congenital kidney diseases or fifth stage chronic kidney diseases, that family members also, or direct relatives or first stage relatives should undergo the screening for chronic kidney diseases. It's unplugged. So when we are dealing with the chronic kidney disease, we have to differentiate it from the is it an acute renal failure or chronic renal failure. So how we will differentiate it according to the symptoms, because mostly the chronic kidney diseases have generalized pruritus and all, increased lethargy will be there. At the with the symptom complexes, it is not easy to differentiate the chronic kidney diseases from the acute renal conditions. And so we have to go for the imaging studies, like sonological differentiation should be needed. But mostly in the sonological conditions, chronic kidney disease will present with small size or renal atrophies will be there. And conditions like polycystic kidneys will have their appearance of cystic lesions will be the cyst will be the water filled cavities will be filled in on the around the renal system. So then chronic kidney disease, according to the National Kidney Foundation, is evidence of there should be 3 parameters should be there to diagnose it as chronic kidney disease, which is it is the evidence of kidney damage based on the abnormal urinalysis. When we are examining the urine, there should be proteinuria, hematuria, like features should be there. And structural abnormalities in sonological studies and glomerular filtration rate less than 60 ml per minute for consequent 3 months or more. Test to assess the renal function. When there are laboratory measures to assess the renal functioning. So when we are writing or prescribing renal function test for a patient, it not only indicates the biochemical parameters like urea, creatinine and all. It includes renal function test includes glomerular function test, tubular function test, biochemical parameters in blood and urine examination. Along with that, we have to do the sonological or imaging studies to differentiate the cause. This is the chronic kidney disease is stage 2, 5. Stage 1 to stage 5 will be there according to the glomerular filtration rate. If it is more than 90 with mild renal parameter changes, it will be kidney damage with normal or it is in the first stage. And if glomerular filtration rate reduced to 60 to 89 means it is stage 2, 30 to 59 means it is stage 3, and 15 to 29 means it is severe condition, and the less than 15 means patient is going to the renal failure. And when we are prescribing glomerular filtration rate for a patient, we should know the normal value of that. It is 125 ml per minute. And there are certain factors which influence the glomerular filtration rate, that are the obesity or the body weight of the patient. According when body weight, as in 2016's estimation, major risk factor for production of chronic kidney disease is obesity. So when weight is increasing, especially the intra-abdominal fat is increasing, glomerular filtration will go down, and it will be physiologically it will be 8% more in males, and in certain races like glomerular filtration rate will changes. So, and in pregnancy, in the initial first trimester and all, 50% rise will be there, and it will become normal after 4 to 8 weeks of pregnancy. And age, according to when age advances, glomerular filtration rate will decline. So these all things we should think parallelly when we are prescribing glomerular filtration rate for the patient. And antihypertensive therapies, which directly or secondarily it can alter the glomerular filtration rate. Cystatin C, that concept of renal function assessment with the help of urea creatinine will change. Now, cystatin C we are more taking as the biomarker to assess the renal health. Cystatin C is an investigation in which it is a protein which we will measure. It advantages of cystatin C in assessing the glomerular filtration rate is it is virtually unaffected by pre-renal causes. Creatinine can fluctuate if there is any motor damages or skeletal muscle damages, or in cardiac conditions, creatinine level can change. So we can't depend upon that to solemnly diagnose the condition. So extensively, and cystatin C is extensively sensitive to small changes in the glomerular filtration. Means how much unit of blood is filtering in the renal tube, glomerular apparatus per minute we are assessing by glomerular filtration rate. So it will cystatin C is very sensitive, and it will detect the early changes in the glomerular apparatus and demonstrate the higher diagnostic accuracy mainly in the type 1 and 2 diabetic conditions, and has been advocated. And along with that, more importance of cystatin C, it will be helpful for the general physician to assess how the medication is acting. If patient have any renal impairment or not, we have to assess. Or we all are using Resaushadis, and many other even all doctors are using analgesic. In allopathic, like they are using analgesics. We are using Resaushadis, herbal preparation. How we will test the efficacy or safety of our medicine? Is that medicines are causing any renal impairment? That we can assess by the assessment of cystatin C. So there are contraindications for performing cystatin C assessment. Means it's not contraindication, because in these conditions cystatin C will fluctuate. Ranges will fluctuate. When we are advocating cystatin C for a thyroid patients, their actual range it will not be a precise value. So it is better not to advise. Then corticosteroid therapy. Usually corticosteroids will not influence the cystatin C levels, but when patient have renal impairment, then corticosteroid therapy will influence the cystatin C levels. And current cigarette smoking. When we are referring a patient for the laboratory investigation, you should not refer them blindly. We have to advise them. They should not go for immediate drug abuse, alcohol, smoking and all, because it can impair the values of cystatin C. And inflammations with high CRP, in that condition also, cystatin C results will not be precise. Then we have to go with the tubular function test. It includes urine concentration and dilution test, osmolarity measurements in plasma and urine acidification test, and phenol red test. These all tests are assessed in, especially urine concentration and dilution test. We are getting idea about the urine specific gravities in concentration and dilution time. Urine specific gravity will change in acute renal failure conditions and all. So, and similarly, these all parameters are assessed to find out any of the tubular parameters are altered or not. So then we are going to the most familiar thing, biochemical parameters in blood. So first one is serum creatinine. Every physicians will add serum creatinine as the basic mark for renal functioning, but actually it is not. It is an insensitive marker or measurement in elderly patients. With the serum creatinine level, we can't tell that that patient is having, if creatinine level is normal also, we can't tell that patient is having normal renal functioning. So what happening is that serum creatinine levels will rise only on the third and fourth stage of chronic kidney disease. That is on the end stage only it will rise, and by that time 70% of the renal damages or nephrons are damaged. So it is not an early indicator, especially in the elderly patients. And according to the serum creatinine level, renal diseases are classified into moderate, severe, and end stage renal diseases. Then next is blood urea. Blood urea is estimated at normal to 10 to 15%, and it is expressed as blood urea nitrogen. Normal range will 7 to 25%. Urea is also not a confirmatory indicator for renal impairment. It will give idea about prerenal causes, renal causes, and post-renal causes. If any cardiac abnormality is also ongoing in that patient, urea level will raise. It is not a clear-cut idea. It is only renal complaint. We can't tell by urea levels. So it is influenced factors. Post-renal and pre-renal factors will influence the urea levels. Then uric acid. Uric acid, everyone equate into the gouty arthritis. It's not only increased in uric acid. In gouty arthritis, uric acid will raise, and it is an indicator for renal impairment also. And all physicians should note that all chronic gout conditions, we have to check the patient's uric acid or renal functioning test should be done, because chronic gout can cause vascular damages, and chronic rheumatic conditions also can cause vascular conditions like nephrosclerosis and leading to renal impairments, and that patient will end up with chronic kidney diseases or renal failure. So if in renal condition, uric acid level will increase from 4 to 20 milligram deciliter. Then there are many electrolyte measurements will be there, but most important we are going in serum inorganic phosphorus. Hyperphosphatemia will be seen in renal conditions or renal failures, and mostly in the end stage conditions we are seeing the hyperphosphatemia. And when we observe hyperphosphatemia in a person, it is indicate that 75% of the renal damage has happened. And hyperphosphatemia is a prognostic indicator also. Is that the condition is going for good prognosis or bad prognosis, we can assess from the phosphorus level. Then next is serum calcium. Initially in acute renal failure condition, we are noticing hypocalcemia. Later in the end stage, it will replace with the hypercalcemic conditions. So we have to confirm that hypercalcemia is only due to renal damage by assessing the parathyroid hormone and ionized calcium levels. If person is having hypercalcemia with reduced or low normal ionic calcium and increased hyperparathyroid hormone level, indicates renal pathology. Then we have to go in precise with what all are the investigatory parameters in chronic kidney disease. So serum urea and creatinine are poor markers that are needed, but they are not a critical indicator for renal impairment. So in primary monitoring, biomarker is glomerular filtration rate and cystatin C. In biochemistry level, we should check for the blood glucose level. Serum sodium will be normal or low, and serum potassium will be raised, which increases the chance of cardiac pathologies, or cardiac risk will be increased in renal impairment conditions. Serum bicarbonate level will be reduced, and hypoalbuminemia, hypercalcemia, hyperphosphatemia will be seen in that patient. And in hypercalcemic conditions, patient will present with tetanic presentation. As hypercalcemia will induce to reduction in vitamin D synthesis and all, and lead to parathyroidism, and that time patient will have tetanic presentation, and during that time we have to check the serum alkaline phosphatase level of the patient, and serum parathyroid hormone and cholesterol, as in renal damages will present with dyslipidemias also. So cholesterol level should also be assessed in a renal impairment condition. Then hematologically, we all know kidneys also have role in erythropoiesis. So there will be obviously we can notice anemia in renal impairment conditions. But what type of anemia? It will be a normocytic and normochromic anemia, and WBC levels will be normal unless it is a nephritis conditions. And other investigations are serum and urine electrophoresis. And for precise differential diagnosis, is it a systemic cause? Then SLE we have to rule out by ANA profile. See, antinuclear cytoplasmic antibodies, we have to check for polyarthritis, vascular, to differentiate the vascular causes. Anti-globular membrane, basement membrane antibodies for Goodpaster syndrome, and all viral markers also we have to assess in chronic kidney disease conditions, because viral diseases like AIDS and all can lead to glomerular nephritis. Then urine analysis, urine full an assessment should be done, and imaging studies. And in which condition, which imaging study we have to select we should be thorough. If we are suspecting about any renal atrophy or renal changes, minor renal changes, we have to go with the ultrasonogram or USG abdomen, specializing KUB, kidney, ureter, and bladder. And if we are suspecting any of the obstructive pathologies leading to chronic kidney disease, that time we have to go with retrograde pylography. And if we are suspecting any renal mass obstruction with calculi and all, we have to go with the CT and MRI studies for renal vein thrombosis, and renal radionucleotide scanning for renal artery stenosis. If the artery supplying to the renal kidney is having any stenosis or reduction in its space, then we have to, if we are suspecting that, we have to go with renal radionuclide scanning, and renal biopsy should be done. Then we have to discuss some of the Mutra Vikaras. When we are considering the Mutra Vikaras, there will be Adipravarti Janitha Vikaras also there, Alpa Pravarti or Krichra Pravarti will be there. Adipravarti, if we are thinking about Mutra Vikaras, it will be in either Pravarti or Alpa Pravarti. Adipravarti Janitha Vikaras we can correlate to the Pramehadis, and Alpa Pravarti or Krichra Pravarti we can correlate to Mutra Ghada and Mutra Krichra. When we are going through the nidanas of Mutra Vikaras, Mutravaha Srodo Dushti Nidanas, Mutridodaka Bashistri Sevanat, Mutra Nigraha, Mutravagini Dushyandi, Shinasya, Abhishadasya. Here Acharya mentioned that there are dietary causes which will lead to glomerular changes, obstructive causes, and traumatic causes. Shada is explained. Ruksha here indicates the chronic debilitating disorders also we can consider it as the Ruksha. And Stri Seva, we can correlate the infective pathologies, and Madhya, alcoholic intoxications, and Tishna Aushadha Seva also explained, drug-induced renal toxicity. Then Mutra Krichra vs Mutra Akhada. In Mutra Krichre, Mutram Krichrena Vahadi. Mutra Krichra is, we can correlate to the nephropathic conditions, and Mutra Gada, it is Mutrasya Shoshana and Pradihanila. So it is clear-cut indication for the Ayurvedic aspect of obstructive uropathy and nephropathy. So kidney health is in our hands, and we should adopt proper hygiene, proper hydration, lifestyle disease management, proper screening, and proper diet, proper rest, and proper stress management to increase our kidneys health. So protect your kidney and lead a healthier life. Thank you all for the patient listening, and thank you all MC committee members, Department of Kaya Chikitsa, and all organizers of World Kidney Day celebration for giving me a chance to share my views. Thank you.
Thank you, ma'am. I now invite Dr. Apitha, PG Scholar, Department of Kaya Chikitsa, to present on kidney diseases.
A very good evening to all present here. Here, I am Dr. Apita, PG scholar, Department of Kaya Chikitsa, here to present on a topic of kidney diseases. Already a gist of idea or a detailed idea is actually been given about the kidney diseases by the previous speakers. Now I am just wanted to concentrate about the overall concept of the kidney diseases and also the treatment aspect which have been made, and I have brought certain kidney diseases here which are incidentally more worldwide, and also we shall see about the treatment aspect on the contemporary sciences, and also a gist of kidney diseases as per Ayurveda and the conceptual analysis of kidney diseases according to Ayurveda. So already the functions of the kidney is being told by Dr. Lakshmi Madam, where the most important kidney is a vital life sustaining organ in the body. And it does the functions such as excretion of metabolic waste, especially it balances the sodium and potassium level. It secretes the hormone which plays an important role in systemic illness. For example, the renin hormone secreted by the kidney, it plays a vital role in the maintenance of the blood pressure. And next is the erythropoietin hormone, which is secreted, will take part in the absorption or the secretion of RBCs in the body, and also the production of vitamin D, which is in an activated form when it is secreted in the body and it is being absorbed in the intestines. And this kidney diseases, such an important organ, will cause kidney diseases if the functioning is not proper. Worldwide, about 1 in 10% are suffering from chronic kidney diseases, and it is also said that 7.8 million of the people worldwide are suffering from the kidney diseases. So kidney diseases as such not generally come as a single diseases, but always there is an underlying systemic illnesses. So the risk factor for kidney diseases will be like previous systemic illnesses like diabetes, high blood pressure, heart rate, obesity, familial history, and also certain risky behaviors like not consuming too much salty and not drinking enough water. Likewise, social and lifestyle problems will also lead to the kidney diseases. So as a physician, we have to diagnose these kidney diseases which are discovered incidentally during a routine medical evaluation. So it can be because on a general screening examination, we can able to identify the renal diseases, or the symptoms of the kidney functions such as uncontrolled hypertension, edema, nausea, hematuria will also give us an idea about the kidney diseases in general. And the initial approach of the treatment for any kind of kidney diseases will be through estimation of the disease duration, careful urine analysis, assessment of glomerular filtration rate, proper history and physical examination. Besides a disease duration, urine analysis such as proteinuria and hematuria will also give us an idea about the kidney diseases. Not only that, there are certain other particulars like general characteristics of the urine. For example, the frequency or the volume of the urine. If there is polyuria, oliguria, or nocturia, that also gives us an example of a underlying kidney diseases. And if there is any other causes like the increased frequency, pH, specific gravity, water content, color, odor, or the bacterial content of the on general examination of the urine analysis will give a specific identification about the kidney diseases. I have got here certain most important kidney diseases incident wise. First is acute kidney disease, chronic kidney disease, polycystic kidney disease, tubulointestinal disease, and glomerular diseases, which includes asymptomatic proteinuria, nephrotic syndrome, nephritic syndrome, microscopic hematuria, and rapidly progressive glomerular nephritis. I would like to say certain symptoms and signs of all these kidney diseases along with the treatment. First, when we take the acute kidney disease, as the name suggests, it is acute in nature. So basically, it will be less than 3 weeks. So the etiology will be any renal hypoperfusion or vascular causes and edema in the body, such as cirrhosis or cardiac failure, will lead to acute kidney disease. And like any other kidney disease, acute kidney disease not necessarily need to have a underlying systemic causes. And the categories of acute kidney disease is very, very important to know and to treat the patient accordingly. So there are three categories in acute kidney disease. One is a pre-renal acute kidney failure, where there will be a decrease in the functions of the glomeruli. And the next one is a acute tubular necrosis intrinsic renal diseases. Here, the tubular cell will lose its function. The third is the post-renal acute kidney disease, where there will be a inflammation. So on categorizing these kind of acute kidney diseases, the treatment will be very much easier. So the clinical features of all the kidney disease will be mostly same, like there will be shortness of breath, fatigue, confusion, nausea, vomiting, pitting edema, there will be vomiting sensation, there will be weakness, debility, feebleness, etc. And especially in case of acute kidney disease, there will be oliguria. So basing on all these things, we have to go for the further investigation. So there are two criteria uh, for analyzing any kind of kidney disease. One is a glomerular filtration rate, which tells us an idea about the glomerular filtration capacity of the glomeruli. And next is the serum creatinine and the urea, which are the markers. And if it is not in a normal state, it will lead to it will lead to an understanding that the glomerular function is not proper. So the overview of treatment of acute kidney diseases relays as we discussed the previous factor. So one is the pre-renal factor, where we have to replace the kidney with the IV fluid. And if there is an high profuse oliguria, or if there is high oliguria present, then there will be high preload of diuretics can also be given. In case of intrarenal causes, the treat the underlying diseases is very, very important. And in case of post-renal causes, the relievation of the obstruction pathology that causes the acute kidney diseases should be eliminated. Next is the chronic kidney diseases. The name suggests the chronicity, which will be more than 3 weeks, and there will be a systemic illness underlying the chronic diseases. So that will make the differences between the acute kidney and the chronic kidney diseases. Never ever in acute kidney disease, it is a compulsory that the underlying systemic causes like hypertension or diabetes must be present, because in acute kidney disease, we will be treating only the symptoms. But in case of chronic kidney disease, the systemic illness which is causing the chronic kidney disease has to be treated first, and then only we can able to see an elevation in the kidney function. So the categorization of the chronic kidney disease have been well described before presentation. And however, the stage 1, stage 2, 3A, 3B, 4B, and stage 5, up to stage 5, the chronic kidney diseases have been categorized, which are caused by, as I said, the systemic diseases like glomerular nephritis, diabetic nephropathy, hypertension, renal diseases, and other uncommon causes, renal vascular disease, or any kind of congenital lesions. So this will lead to pathologies like uremic toxins in the body. There will be impaired production of erythropoietin and vitamin D, renal osteodystrophy, and there will be middle molecule. So this middle molecule is nothing but the uremic toxins that is getting accumulated in the body. So here I have brought this pathophysiology in order to understand, and accordingly, after understanding these pathogenesis, we can directly go for the treatment. So the symptoms is very similar like that of an acute kidney disease, but here there will be other system involvement also, like cutaneous involvement, where we can see skin rashes, dryness, or any other skin pathology will be involved in case of chronic kidney disease, that too in particular to the chronicity. And also certain other bone deformities will be seen, because there will be vitamin D synthesis will be hampered, and the patient will be generally anemic, as the erythropoietin secretion will be hampered. So this chronic kidney disease, depending upon the functioning, symptoms, and also the biometric parameters, can be categorized, and the progression of the chronic kidney disease will be dependent upon it. So the management will be hyperkalemia resistant to medical therapy. Next is metabolic acidosis resistant to medical therapy, uremic symptom therapy, uncontrolled hypertension treatment, and neuropathy and encephalopathy treatment. All these therapies has to be managed and overviewed, and accordingly this chronic kidney disease has to be managed. The next is the polycystic kidney diseases. However, this polycystic kidney diseases is present worldwide because it is mostly inherited, that too especially autosomal dominant diseases, and it is characterized by bilateral cysts that causes not only a structural involvement but also functional disturbances to the kidney, because as the cyst enlarges, the renal tissue will get compressed, and as I said, there will be autosomal dominance, especially PKD1 and PKD2. So the symptoms of the polycystic kidney diseases will be panting or fluttering in chest, increased in size of abdomen, muscle cramp, frothy urine, anemia, kidney or bladder infection, which will be more frequent, high blood pressure, blood in urine, weaknesses, and the classical polycystic symptoms like UTI, hematuria, loin to groin pain can also be present here. And as such, in contemporary sciences, there is no evidential treatment for this polycystic kidney diseases, while they are saying there are certain somatostatin composition which will help in preventing the growth of the disease, but it is not also as enduring as that of Ayurveda. Next is tubular intestinal diseases, where there is scarring of the intestinal tissues of the kidney, and it is of two. One is an acute, another one is a chronic intestinal diseases. And since it is a scarring, it is mostly caused by an intrinsic factors like lithium toxicity, metal intoxication, outside in extensive infections such as HIV, measles, salmonella, or radiation. And the symptoms will be urea and fluid overload. So basing on the symptoms, the treatment of the tubulointestinal disorder should also be taken place. However, a clarity regarding a specific treatment for tubulointestinal diseases cannot be made because it is dependent on various factors. But generally, correcting the underlying disease and renal replacement therapy in case of higher chronicity or an end stage, this will be adopted. Next is the glomerular diseases, which is found in most of the kidney disease. The most common kidney disease will be a glomerular diseases. It is not just limiting to the inflammation or an infection that is happening on the glomeruli, but there is also structural, functional factors that are causing injuries and manifest symptoms and signs. And here in glomerular nephritis, we can see other pathology with the involvement of histopathology, HLA complexes involved in it. So this glomerular diseases will cause asymptomatic proteinuria, nephrotic syndrome, nephritic syndrome, hematuria, progressive glomerular nephritis, and it is also categorized primarily primary glomerular diseases and also systemic globulopathies. Here in glomerular neuritis, the treatment will be based on the symptoms, the systemic illness that are being involved. So the identification of the glomerular nephritis here plays a very major role. So the basic identification will rely on the general characteristic of the urine, that is either the proteinuria or the hematuria, which will give an identification about the glomerular diseases. And the glomerular diseases will also be having a presenting complaints which will be mostly asymptomatic. So whenever the patient goes for the general examination, this kind of diseases can be predicted. Then there will be fatigue, lethargy, hematuria, frothy urine, swelling or oliguria will be present. And also the signs like hypertension, edema and urine dipstick for protein also give us an idea about this glomerular diseases. Suppose if this glomerular diseases, because of this asymptomatic nature, if it is not treated or if it is not identified properly, then the renal function will decline and it will lead to end stage renal failure. See, this end stage renal failure is being categorized with the symptoms like weight loss, weakness, fatigue, muscle cramps, swelling, easily brushing, and peripheral neuropathy, trouble concentrating, reduced appetite, vomiting, extreme thirst, abnormal light or dark patches on the skin. So there will be multiple system involvement in this kind of end stage kidney diseases, and that actually gives us an idea about the progression of the diseases. Addingly, the GFR also gives us an idea about the end stage kidney disease. So the overall treatment aspect for any kind of kidney diseases are being categorized in a contemporary science, like they first prefer angiotensin converting enzyme inhibitor or angiotensin 2 receptor antagonistic, which are always recommended as a first line agent, because mostly the kidney diseases are because of increased hypertension, or if any other diseases, so there will be definitely a variation in the blood pressure, and hence these kind of drugs are being chosen at first stage. Next is treatment of high blood lipids. Next, a low protein, low salt diet may result in slower progression of chronic kidney diseases, and this will reduce the proteinuria. And target treatment for anemia should also be given. So these concepts are actually very much similar to that of Ayurveda, because as we are considering kidney as vrika, it is a organ which makes the medas and rakta, so which is very similar to that of the contemporary sciences treatment adaptations also. Then calcitriol is recommended for vitamin D deficiencies, and also there is lifestyle interventions like weight loss, dietary salt restriction depending whether the person is hypertensive or not, and omega 3 fatty acid supplements, because there will be a muscle loss in it. These kind of fatty acid supplements will actually enhance the energy level of the patient. Next is protein supplement, iron supplement, and a proper sleep, and maintaining a proper hormonal imbalance through circadian rhythm is also very important in kidney diseases. And if it case of chronic kidney diseases, there will be kidney replacement therapy, which includes dialysis or kidney transplantation, or other methods like hemodialysis, peritoneal dialysis, or kidney transplantation will be adopted in all the cases depending upon the stages of a kidney diseases. So when we talk about, or when we analyze about an Ayurvedic perspective of kidney diseases, so whenever we say kidney, we get into the terminology of vrika. So vrika especially is said in the concept of Medo Dhatu or Medo Vaha Shrotas. The moola of Medo Vaha Shrotas is vrika. And anatomically and physiologically, if we see the vrika, it can be maintained only if the Medodhatu health is proper. That is, Medodhatu or the Medovaha Shrotos should be properly maintained in order to maintain the health of the vrika and the functions. So that depends mainly on two factors that can be analyzed in two ways. One, through Kedara Kulya Nyaya, where from Rasadhatu, that is from Jataragni, from Rasadhatu, Rasa, Rakta, Mamsa, Meda, that Dushti through Kedara Kuleraya from the Agni concept can be taken into consideration. And another one is the Vrika Roga can be balanced by maintaining the, or by preventing the karana that causes the Medo Roga Dushti, and also Mutra Vaha Shroto Dushti. So by preventing or analyzing these two factors, the Vrika Roga can actually be identified. Basically, if we see about any kind of renal diseases, there will be a underlying systemic illness present. For example, hypertension. So bringing that hypertension into Ayurveda, we need the help of doshas like Rasa, Rakta, etc. Or if it is in case of Prameha, we have to bring out Rasa, Rakta, Mamsa, Meda, Lasika, Ambu, etc. If it is a Staulya, we have to bring out the Medo Dhatu here. So all these factors has to be brought about here, and we have to analyze what kind of kidney disease it is. And also, we should never forget the basic concepts of Ayurveda. That is, first, or while treating any kind of diseases, the first factor that is taken into consideration is the Nidana Parivarjana. So here the Nidana Parivarjana can be in base of many factors, like not only treating the Lakshana, or not only preventing the Nidana, both the Manasika Karana and the Sharirika Karana has to be considered before undergoing a Nidana Parivarjana. Because as I said, a renal failure will be having a systemic illness involvement. So any kind of stress or Manasika Bhava like Krodha, Shoka, Bhaya will always lead to disturbances in the Dhatu and the Dosha. So a Manasika and the Sharirika factors has to be considered. And next is Lakshana Viparita Chikitsa. Here when we see the Lakshana Viparita Chikitsa, the Karana will be either the systemic illness like hypertension, Prameha will also be a Karana for this kind of Vrika Roga that causing symptoms like Daurbalya and Agnimandyatvam, etc. And also certain other roga can also be brought into this Vrika roga. For example, Pandu, even if it is explained separately, it has to be brought into the Vrika roga or the Samprapti of Vrika roga, and we have to consider the Nidana, Samprapti, Lakshana, and accordingly we have to treat this Vrika roga. And as such in Ayurveda, Vrika roga, the terminology, other than that, there can be consideration regarding the Medodhatu and also the Mutravaha Shrota Lakshana. And the base of the Chikitsa should also be done based on these karanas and by considering the quantity of the dosha involved, whether it is Bahudosha involved or whether it is Alpadosha involvement, the treatment has to be based on it. So if it is Alpadosha, we can go for the Shamana therapy, or if it is Bahudosha, the Shodhana can be done. And not just limiting to Nidana Parivarjana or Lakshana Viparita Chikitsa, Ayurveda can go a step ahead in preventing the end stage terminal function of the kidney also. So the reversibility of the kidney function is also possible through Ayurvedic medicine, not just with Shodhana and Shamana, but also by the prayoga of various rasayana. So, n number of Aushadha Prayogas are actually being described in various Samhitas, and this selection of the Yoga Prayogas has to be done based on the Dosha and Dosha Vikalpa and the Lakshanas and the Matra, Vaya, Kala. These, according to these factors, these medications has to be chosen accordingly. So, a direct indicative medication for an acute kidney disease or a chronic kidney disease is never a possible criteria in case of Ayurvedic perspective. So based on all these things, a case report was being done by Dr. Suvendu Rautsa, a patient named Ranganathan of 49-year male with OPD number 7831/90, who's a known case of chronic uncontrolled hypertension, approach with the complaints of swelling in both the lower leg, pitting edema, loss of appetite, nausea symptoms. So on routine screening, there was elevation of blood pressure, that is 160/90, and there was rapid increase in the creatinine, urea values, and also decline in the HP percentage. So accordingly, the patient approached on 19/8/2019 with the medicines such as syrup Niri KFT, Gokshuradi Churnam, which is our own medication, that is Anubhuta Yoga of Jayendra Saraswati, was being given, which is of composition Gokshura, Rasna, Badara, Prishniparni, Yashtimodhu, were being given 10 grams with half glass of water as Kvata prepared on the first day. And on 23/8/19, the same medicine which was being continued by the patient, on seeing the value of the creatinine, there was a rapid decline. It was 7.6 mg/dl. And on 29/19, in September month, the medicines was included for hypertension and also for anemia, like syrup 4 blood or tablet Sarpagandha Bhatti. And on 22/10/90, all the medications was being sturdily continued by the patient, and there was further decline in creatinine value from 7 to 6.6 mg/dl. And in the month of November, there was a rapid decline from 10.2 to 5.1 mg/dl in the value of creatinine and urea. So as a result, there was changes in the kidney biochemistry parameters was observed in that patient, and there was marked improvement was seen in the level of hemoglobin from 6.6 to 11.2 mg/dl is seen, and there was symptomatic improvement in the swelling, and other symptoms such as nausea, loss of appetite were also being corrected, and the blood pressure was regularized with an Ayurvedic medicine. And the treatment was not just an Aushadha Chikitsa, but it also comprised of medications, lifestyle modification, and also food regulations. So then approaching a kidney diseases with a medicine and making the patient to suffer psychologically, it is better, and it is our responsibility as an Ayurvedic physician to bring awareness to the public by saying certain preventive measures for kidney diseases. So as per which the patient should be advised, or the public should be advised, to manage their blood pressure, eat a healthy diet, manage their blood sugar, reduce salt intake has to be recommended, and maintain a healthy weight, drink enough water, limit over the counter painkillers or pain medication limitation should be advised to the patients also. And also, I would like to complete this session by the Acharya Charaka sloka, that अजातानां मनुत्पत्तौ जातानां निमित्तयो रोगाणां यो विवृदृष्ट सुखार्थ समाचरेत् सुखार्थ सर्वभूतानां मत सर्वप्रवृत्तयः ज्ञान अज्ञान विशेषार्थो मार्ग प्रवृत्तयः. So what he says is that to prevent a manifestation of a disease, a proper regimen has to be followed. That is been mentioned in our science, that goals at achieving the happiness through proper psychosomatic activities and also well-being. So as an Ayurvedic doctor, we have to educate the patient in a preventive aspect, and also we have to have that confidence to undertake these kind of kidney diseases, and we have to show to the public or the world that Ayurvedic treatment do have a better ideology, do have a better result than compared to the contemporary sciences treatment. Thank you so much.
Thank you, Dr. Apita. I now request Dr. K. Guruprasad Sir, Professor, HOD of Swasthavrata Department, to enlighten us on topic Diet and Yoga in Chronic Kidney Diseases.
Good evening to all. On the occasion of World Kidney Day, as my specialty is on Swasthavrata, I am going to talk on Patya and Apatya and Yoga in chronic kidney diseases. So as classical says that Prakshalanati Pankasya Durat Sparshanam Varam, which says prevention is better than cure. So to prevent the diseases, one has to follow the principles of Ayurveda and Yoga. So these are already covered by previous speakers regarding general symptoms, and also vulnerable population who are prone to get kidney diseases. These are diabetes, hypertension, obesity, and also family history of chronic kidney diseases and heart diseases and old age. These are a vulnerable population to get the diseases, kidney diseases. These are also influencing factors who are more prone to get chances of kidney diseases. Problem statement, in worldwide, total 850 million people suffer from kidney diseases. In that, estimated that 1 million people die with untreated kidney diseases every year. And also in India, 10 crore population suffer from chronic kidney diseases. In that, 15 to 20% death in every year in India. So these are apatya in kidney diseases, whole cereals, legumes, nuts, oil seeds, sesame seeds, tomato, beetroot, leafy vegetables, cucumber, cashew nuts, mushrooms. These are all containing of more of rich in phosphorus, oxalates, and which are not good for the kidney. And also the regimens which are apatya in kidney diseases are sedative lifestyle, improper sleep, and suppressing of urges like micturition and also thirst. So these leads to kidney diseases. And also one has to follow or take more of these type of diet to avoid or enhance the health of kidney. So rice, wheat, barley, horse gram, almonds, carrot, bitter gourd, buttermilk, and pineapple, banana, coconut water, green tea, orange, and lemon. So these are good for the kidney and also enhances kidney health. And activities, the regimens which can also follow to enhance the kidney health are active lifestyle, appropriate sleep, exercise and yoga for 40 minutes daily, and proper liquid intake, and meditation for psychological health. So this is a daily menu. I have given some of the regarding the breakfast, lunch, and dinner, but it is not a standard one. It can be changed according to the patient chronicity and the region. Also, you can change, and availability of food items. Also, we can change the menu. Approach of yoga. So yoga plays important role in enhance the kidney health. Before starting off yoga, one has to go for loosening exercises or brisk walking, jogging, cycling, which gives a sweating to the body. Okay, which gives sweating to the body. And also when I search for to enhance the kidney health, so these are the asanas beneficial to prevent the kidney diseases and also enhance the kidney health. So this is Salamba Bhujangasana, Ardhamatsendrasana, Paschimottasana, Setubandhasana, Naukasana, Mandukasana, Shashankasana, Pavanamuktasana. These are the beneficial for enhance the kidney health. Also, pranayama plays important role in enhancing kidney health. Those are Nadi Shodhana pranayama, Bastrika, Brahmari, Surya Bheda, and Kapalabhati Kriya. These are best in enhancing kidney health. So also dhyana plays important role in psychological health. Dhyanam nirvishayam mamaha. So dhyana will make a person to psychologically healthy. Presently diseases are psychosomatic origin. So person should be psychologically strong. So dhyana will plays important role in psychological health. So to conclude my talk with this quotation, when diet is wrong, medicine is of no use. When diet is correct, the medicine is of no need. So even Ayurveda says that ahara is a half of the treatment. Half of the treatment is medication. If you follow the ahara, no need of treatment also. So thank you one and all.
Now, I call upon Dr. C. Muthunagai, PG Scholar, Department of Panchakarma, to present a case report on end-stage renal disease treated by Dr. Praveen B.S. Sir, Professor, Department of Panchakarma.
Respected Principal Sir, Vice Principal Sir, all faculty members, and my dear friends, good evening to all. I am Dr. Muthunagai, PG Scholar from Department of Panchakarma. I feel privileged to present before you a case of end-stage renal disease of stage 5, which is reversed to stage 4. End-stage renal disease being one of the common complications of diabetes, the mortality rate is significantly high from 20% to 20% to 50% over 24 months, even with timely dialysis. The higher mortality rate is within the first 6 months of starting the dialysis. Here I am going to present a pragmatic treatment approach to end-stage renal disease through Ayurveda, treated by Professor Dr. Praveen B.S. Let me go to the presentation. A 49-year-old male patient who was a known case of type 2 diabetes mellitus, systemic hypertension, chronic kidney disease of stage 5, undergoing weekly 3 days of maintenance hemodialysis, came to Sri Jayendra Saraswati Ayurveda Hospital, IPD, on 6/1/2023 with complaints of nausea, decreased appetite, heartburn, abdominal pain, decreased urine output, approximately 400 ml per day, constipation, pruritus, fatigue, difficulty in sleeping, depression for the past 2 months. Symptoms of uremic gastritis gets worsened during hemodialysis and was managed with IV of proton pump inhibitors. He is a known case of type 2 diabetes mellitus for the past 20 years and systemic hypertension since 3 months under modern medication. On examination, he had prominent uremic symptoms and also tunnel catheter for hemodialysis. Urine output was around 450 ml per 24 hours. His vitals were pulse rate 96 per minute, BP was high, 170 bar 110 mmHg. Timeline of medical history and the treatment undergone by the patient follows. On 24/12/22, patient got admitted at Chettinad Hospital, Chennai, with the symptoms of nausea, heartburn, decreased urine output, pruritus, difficulty in sleeping, decreased appetite, abdominal pain, constipation, fatigue, and depression. The hematological investigation, you can see the elevated levels of uric acid, serum creatinine, decreased EGFR, fasting blood sugar was high, your procalcitonin was positive, and also prothrombin level was also high. His liver function test, lipid profile, and serum electrolytes were within normal limits after the hemodialysis. Another investigation, CT abdomen showed grade 1 renal parenchymal changes. Upper GI endoscopy showed antral gastritis and corpus gastritis. So at Chettinad Hospital, the patient had undergone hemodialysis session, 4 sessions. These were the medications given. The outcome, patient had symptomatic relief. Adrenal function test came to normal limits. But after the hemodialysis, again, when the patient was discharged with the advice of 3 days of hemodialysis per week, exacerbation of symptoms and elevated renal function test happened. So he came to Sri Jayendra Saraswati Ayurveda Hospital. He got admitted on 6/1/23. He was diagnosed as having Prameha Upadrava and Mutra Kritra and Mutra Gata. The internal medications given were Varanadi Kashayam, Punarnavasavam, Suftin tablet, Anuloma DS, Punarnava Manduram, Liv 52 and Mahasankavati. He had undergone the following Kriya Kramas: Abhyangam with Shirabala Tailam from 7/1/23 to 29/1/23. Nadi Svedam was done. Shirodhara with Mutta Amalaka Siddha Takra. Shiro Pichu with Himasagara Tailam. Avagaha Sveda with lukewarm water. Karmavasti. Anuvasana Vasti was given with Mahatikta Gridam and Dhanvantra Tailam till 21/23. From 21 to 29, Vasti Amayanta Gridam was given as Anuvasana Vasti. Niruha Vasti, Makshikam, Levanam, Sukumara Gridam, and again after 21 to 29, Vasti Amayantaka Gridam was given as Sneham, Kalkam of Manjista, Trifala, and Punarnava, Kashayam, Punarnavastika Kashayam. Avapidaka Sneham was given with Vasti Amayantaka Gridam. So at 8 a.m., 80 ml was given. 8:30 rice gruel was given. Then 11:15 he had good appetite, and again rice gruel was given. Shunti jala paniya was given, and at 4 p.m. second dose of gridam of around 80 ml. Then at 8 p.m. when he got appetite, rice gruel was given. So on that particular day, urine output was around 1,200 ml per 24 hours. So we can see the output on the right end. So day 3, urine output was improved. Day 5, constipation reduced. Then gastritis symptoms reduced after first week. Depression gradually reduced from second week. Pruritus reduced from second week. Then patient got discharged from our hospital. Advice on Ahara and Vihara at the time of discharge was taken from Dr. Guru Prasad sir. These were the discharge medicines given. So these are the results. You can see the urine output on 9/1/23, it was around 250 ml per 24 hours. And on the day of Avapidaka Snehapana, it was 1000 ml or around 1 liter. And then gradually it has been increased. Now on 21 to 23, the urine output has been increased to 1000 ml for 24 hours. Nausea, On 9/1/23, it was most of the time he had nausea. Then at the time of discharge, he did not have any nausea. Until now, it is maintained. Appetite, when he got admitted, he did not have any appetite, and gradually it got improved, and now he has very good appetite. Motion, he had very hard bowel that he had to evacuate digitally. Then on 2/2/23, February 23, consistency was normal and it is still maintained. Heartburns and stomach pain, it was there throughout the day on 9/1/23. Then it has reduced and now he has no heartburn at all and still maintained. Fatigue and depression on 9/1/23, it was very high. Now the patient's depression has reduced a lot. Pruritus, we have used the scale 5D itch scale, where the numeric rating scale was around 16. It is moderate, and now it is rare. That is numeric rating scale is around 7. So these are the hematological parameters. Urea was around 81 on 6/1/23. On discharge, it became, actually it was elevated, and 92, it is still maintaining. But creatinine level has been reduced. It was around 5.8. This is between the dialysis sessions and Ayurvedic treatment. On February 2nd, again, it came down to 4.36. Now, at the time of discharge on 6/2/23, it has reduced to 3.31. And now this is the latest report. It is 3.13. So creatinine level is maintained. eGFR level, which is the accurate mark for end-stage renal disease, this indicates the stage 5, that is below 15 ml per minute. This was taken on 6/1/23. At the time of discharge, it has been reversed to stage 4, that is below 20 ml. Now on 21/2, it is maintained, that is below 22 ml per minute, eGFR. BP, which was not controlled at all, it was around 170/110 at the time of admission. Then at the time of discharge, it has been reduced to 130/80. Fasting blood sugar, which was elevated 168 mg/dl. At the time of discharge, it was 87. Now it is actually 91.1. Again, it is within normal limits. HbA1c, it is 5.1% at the time of admission. Now it is 6.3%. We should note that all these parameters are without dialysis for a period of 1 month. Uric acid was around 9 mg/dl at the time of admission. Now it has reduced to 6.31 mg/dl. Cystatin C, as madam told, it is also a very accurate marker to see the mortality rate, which was not checked at Chettinad Hospital. It was checked only here in our hospital, but it was under normal limits. So hematological parameters has shown gradual improvement, but symptomatically the uremic gastritis symptom has reduced significantly. Urine output has improved significantly. Blood pressure and blood glucose level are controlled significantly. And hemodialysis was stopped on the 2nd week of admission in our hospital as patient developed severe uremic gastritis. Until now, dialysis has not been done. The evidence-based medicine. So this is the discharge summary from the Chettinad Hospital. This is the eGFR level, which is below 115. You can see the urea level and creatinine level, 81 and 5. This is again on 6/1. This is at the time of discharge, urea remains to be elevated 92, but creatinine has come down 3.31. Here again, this is taken, the patient is from Oman. So this is taken there. You can see the creatinine level and also EGFR. EGFR is around 22 now. So uric acid level has reduced. Urea remains to be high. Creatinine has reduced and EGFR has improved. This is the latest report taken on 21/2/23. So this is the testimonial given by the patient. I have taken only 2 minutes of the entire video, so no worries. Unfortunately, due to the technical issues, the video is not playing. I'll try to bring the video. While the contemporary Western medicine has only the option of dialysis and kidney transplantation, Ayurveda is giving a ray of hope. Thank you for giving me the opportunity. Thanks for patient hearing.
Thank you for sharing the success story. Now I invite Dr. Vipin S.G. Sir, Associate Professor, Department of Kaya Chikitsa, to deliver vote of thanks.
Om Sri Gurubhyo Namaha. A warm good evening to one and all. On behalf of the Sri Jayendra Saraswati Ayurveda College and Hospital and the PG Department of Kaya Chikitsa and the coordinating team, I feel honored and privileged to deliver the vote of thanks and acknowledge the contribution of those who worked really hard to make this program happen. First of all, I bow my head to the lotus feet of Swamigal, His Holiness Pujya Sri Shankara Vijayendra Saraswati Swami. With his blessings and grace, we were able to make today's event a resounding success. To our Honorable Vice Chancellor, Professor Dr. S.V. Raghavan Sir, Empowerment Committee members of SUS VMB, I extend my deepest sense of appreciation for their support and guidance. I express my sincere thanks, gratitude to our respected Principal Dr. Chittaranjan Das Sir for delivering the presidential address and his constant support. I also thank our Vice Principal and Medical Superintendent Dr. Praveen B.F. Sir for providing support and guidance for conducting the medical camp in our hospital in connection with the World Kidney Day. We have been fortunate enough to be backed up by the management committee members for their constant support and motivation. I would like to thank Professor Dr. Pradeep Kumar Sir and Professor Dr. Suvendu Raut Sir, PG Department of Kaya Chikitsa, for delivering the welcome speech and keynote address respectively. Words are not enough to thank our presenters for the day, Dr. Lakshmi, Dr. Kartika, Dr. Apita, Dr. Guruprasad Sir, and finally Dr. Muthu Nagai for their wonderful and encouraging session. A special mention to our respected AO, Mr. Shankar Narayan, who is a constant support for us in organizing this event. With deep sense of gratitude, I thank all our entire teaching staff who always stand by us and motivate us. With a deep sense of pride and respect, I would like to thank the UG students, PG scholars and internees for circulating the pamphlets for the medical camp to different areas and for attending and coordinating the program. Last but not the least, I would like to thank all the non-teaching staff, Mr. Vijay Priyan, Mr. Suresh, Mr. Ramakrishnan for the technical and office support in organizing the event. If time is money, then today we have spent millions for us. Thank you all of you for making the event a grand success. Cheers.
Thank you, sir. Please rise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब